Welcome back to the deep dive. As general practitioners, it feels like we're constantly bombarded with patient complaints every day. And dizziness has got to be one of the trickiest. It's one of those things that just makes your head spin. Well, figuratively, of course.
Right. And, for a busy GP trying to sort through all the possible causes of dizziness, it's like, well, it can feel overwhelming, to say the least.
Oh, absolutely. It's like navigating a maze, blindfolded almost.
Exactly. But luckily, you've come to the right place. In this deep dive, we're going to break it all down. We'll focus on, how to differentiate between the types of dizziness,
Yeah,
and then hopefully, land on a good diagnosis and treatment plan for your patients.
perfect. And we've got some great research and
Yeah.
expert insights to share with you today. So let's jump right in.
Sounds good.
First things first, we got to remember that dizziness itself, it's not really a diagnosis, right?
Right.
It's a symptom,
It is.
and it covers a whole bunch of different sensations like vertigo, lightheadedness, feeling off balance, you name it.
You got it. It really does. So the first step, the crucial step, is really figuring out what your patient means when they say, "I'm dizzy."
Yeah, totally.
What are they actually experiencing? Because, their description, it's like a compass.
Yeah,
It points you in the right direction.
totally. But we all know patients don't always speak in clear medical terms. They might say dizzy when they really mean, I don't know, presyncope
Oh, for sure.
or disequilibrium. So it's up to us to really dig deeper and figure out what they're actually feeling.
Couldn't agree more. Asking, those open-ended questions and really listening to their story, it's key. For instance, if a patient says, "I feel like I'm going to black out," you might ask, "Well, do you mean you feel lightheaded or like you might faint?"
Yeah.
Clarifying those details, that can make a world of difference.
Oh, absolutely. Those subtle clues, they make all the difference. Now let's dive into the different types of dizziness, starting with, I think, the most common one, vertigo. Wouldn't you say?
Yeah, vertigo's definitely up there. It's that false sense of motion. Patients often describe it as a spinning sensation, but not always.
Interesting.
Yeah, sometimes it's just, off balance
Yeah.
or just disoriented.
Okay, so how do we tell the difference between vertigo and all those other types of dizziness?
Yeah.
What are the telltale signs we should be looking for?
Well, a hallmark of vertigo is that it always gets worse with head movement. That's really important to remember.
Got it. So if a patient says, my dizziness gets worse when I turn my head or, when I look up, that's a pretty strong sign it's vertigo, right?
Exactly. And here's another thing. Vertigo is never continuous for more than a few weeks. Even if there's permanent damage to the vestibular system, the brain adapts,
Yeah.
and that spinning, it eventually stops. So if someone's telling you they've been dizzy for months, well, it's probably not true. Vertigo
Right.
could be something else, maybe even psychological.
Oh, that's a really, really helpful tip for us GPs.
Hmm.
It helps us eliminate some possibilities right away. Now, what about nystagmus? That's often associated with vertigo, right?
You're right. Nystagmus, that involuntary eye movement,
Ah,
it's a strong indicator of a vestibular problem,
right.
which means, it's likely related to the inner ear or the balance centers in the brain.
Mm,
But it's not just about the presence of nystagmus.
right.
The specific characteristics can tell us even more,
Yeah.
like whether it's suppressed by visual fixation or which direction it beats in. Those things can help differentiate a central cause, meaning something in the brain,
Mm.
from a peripheral cause in the inner ear.
So we're not just looking for nystagmus, we're analyzing it.
You got it.
Okay. Now, besides head movement and nystagmus,
Mhm.
are there any other red flags we should be watching out for when we're thinking it could be vertigo?
Yeah, for sure. Pay attention to any other symptoms the patient mentions. Hearing loss, tinnitus, anything ear-related usually points towards a peripheral cause, probably in the inner ear. On the other hand, if they have neurological symptoms like double vision,
Yeah.
slurred speech, weakness, that kind of thing, could mean it's a central cause, meaning the problem's in the brain.
Okay, so all these clues,
Mm-hmm.
the patient's description, the nystagmus, the other symptoms,
Right.
whether head movement makes it worse,
Yeah.
they all help us figure out which type of dizziness we're dealing with.
Exactly. It's like putting together a puzzle.
It is. Each piece of information gets us closer to that diagnosis.
You got it.
All right, let's move on to the next type of dizziness. What about presyncope?
So presyncope, that's that feeling of, impending faintness, lightheadedness, like you're about to black out. Some people describe it as graying out or a feeling of warmth. And unlike vertigo, presyncope usually only happens when the patient is upright.
Oh, interesting. So if they feel fine lying down, but get busy when they stand up, that's a clue. It might be presyncope.
Exactly. And think about the usual triggers, right? Standing up too quickly, certain meds, dehydration, underlying heart problems. Those can all cause that drop in blood pressure that leads to presyncope.
That makes sense, especially in older patients. We're
Yeah.
more likely to experience those things. So what's next on our dizziness list?
Okay, let's talk about disequilibrium. This one's a bit trickier. It's a sense of imbalance
Yeah.
or unsteadiness when walking,
Mm-hmm.
and people feel like they're going to fall.
We see this a lot in our older patients,
Right.
especially those who already have trouble getting around.
You see it a lot, and it's often linked to neurological conditions, things like peripheral neuropathy,
Right.
Parkinson's disease,
Hmm.
or problems with the cerebellum, which helps with coordination.
So in those cases, a good neurological exam is super important, right?
Absolutely. You got to assess their gait, their balance, and look for any other neurological signs.
Right.
And sometimes, even vision problems can contribute to disequilibrium, so it's important to consider that too.
This is great. We're really seeing how a thorough history and physical, those are critical for untangling these dizziness causes. Now, what about that last category, the one no one likes to talk about? Non-specific dizziness.
Ah, yes. Nonspecific dizziness. It's the most challenging one because it's so hard to define. It's that dizziness that doesn't really fit neatly into any of the other categories.
So what do we do when a patient comes in and says, I'm dizzy, and we can't get anything more specific than that?
Well, the first thing is to rule out the other causes we've talked about, right?
Right.
Make sure it's not vertigo, presyncope, or disequilibrium. Then you got to start thinking more broadly.
Like what? Give us some examples.
Yeah, it could be, anxiety or hyperventilation.
Okay.
Believe it or not, sometimes purposely making the patient hyperventilate in the office
Wow.
can actually be a helpful diagnostic tool. If their symptoms during that match their usual dizziness, well, there's your answer.
Interesting. So a little controlled breathing exercise can help solve the mystery.
Sometimes, yeah. Also, think about medication side effects. Lots of drugs can cause dizziness.
Right.
So definitely review their med list. And don't forget about metabolic issues like hypoglycemia.
Oh, you're right. Got to keep those zebras in mind.
Yeah.
It really is a full body investigation.
It is. It is. And sometimes, even after a thorough workup, the cause remains a mystery. In those cases, it's all about reassurance and managing any underlying anxiety
Yeah.
or psychological factors.
It's good to remember that sometimes the best we can do is offer support and help them cope with the symptoms, even if we don't have a clear diagnosis.
Couldn't agree more. A good therapeutic relationship can go a long way in those situations. Now, before we move on, I think it's important to highlight dizziness in older adults.
Oh, yeah, that's a whole different ballgame. It's so common in our practice.
It is incredibly common, and often there are multiple factors at play, which, complicates things even further.
It really is like a perfect storm. You've got age-related changes, medications, underlying conditions, sometimes even social factors.
It's a lot to consider. So, what should we be paying extra attention to in these patients? Well, a history of falls is a huge red flag.
Right.
Impaired balance, postural hypotension, and polypharmacy are also big concerns. You really need to look at the whole picture, assess their overall health and how well they're functioning.
And you know what? We can't forget the impact it has on their lives.
Yeah.
I mean, fear of falling, being isolated,
Yeah.
even depression, all those can come from just feeling unsteady on their feet.
Definitely a domino effect we got to keep in mind. So we've covered the main types of dizziness,
Yeah.
but how common are each of these in our day-to-day? Do we have any data on, prevalence and stuff?
Yeah, that would be helpful to know.
We do. There's some interesting research out there looking at how often each cause shows up in different settings, like primary care,
Yeah.
specialized dizziness clinics,
Yeah.
ERs, that kind of thing.
That's great. It helps us see the bigger picture. What did they find?
Well, no surprise, vertigo was the most common across the board, around 45 to 50% of cases.
Okay.
But here's the interesting part. The specific types of vertigo,
Yeah.
those varied depending on where the patient was seen.
So location matters.
It seems so.
Mm.
For example, BPPV, benign paroxysmal positional vertigo,
Right.
that was way more common in primary care and dizziness clinics compared to the ER.
Makes sense. BPPV often goes away on its own,
Yeah.
or we can treat it easily with things like the epi.
Mm-hmm.
So those patients are less likely to end up in the ER.
Exactly. But then more severe types like vestibular neuronitis,
Mm-hmm.
that was more likely to send someone to the ER.
Interesting. So How did the other types of dizziness stack up in this research?
Well, psych disorders were a significant cause in primary care and dizziness clinics,
Right.
which really highlights that we got to consider psychological factors, you know?
It's all connected, isn't it?
Yeah.
The mind and body, they constantly influence each other.
Oh, absolutely. Got to treat the whole patient, not just the symptoms. Speaking of treating the patient,
Yeah.
let's shift gears a bit and talk about those key features that help us distinguish between central and peripheral vertigo.
Okay.
Remember, central means it's in the brain,
Right.
and peripheral usually means inner ear.
Right. And making that distinction is super important because it guides our management
Yeah,
and helps us decide if we need more testing.
you got it. So let's talk about nystagmus again. There's one study that really clearly outlines the differences in nystagmus between peripheral and central vertigo.
Oh, perfect. That's really helpful.
Definitely. And the patterns are pretty distinct. With peripheral vertigo, the nystagmus, it usually beats in one direction, unidirectional.
Uh-huh.
And it typically gets better when the patient focuses their eyes on a fixed point, so it's suppressed by visual fixation.
Okay. So if the nystagmus goes away when they stare at something, that points to a peripheral cause.
Exactly. It's because the inner ear, it's responsible for coordinating eye movements with head movements.
Right.
When there's an inner ear problem, you get that nystagmus trying to compensate. But when they focus their eyes, the visual input overrides those weird signals.
That makes sense. What about central vertigo then? What does the nystagmus look like there?
While with central, it's more variable. It could beat in one direction or multiple directions.
Okay.
And importantly, it often doesn't go away with visual fixation.
So if the nystagmus sticks around even when they focus on an object, that's a red flag for central.
Exactly. Think about it. The problem is in the brain itself,
Yeah.
not just signals from the inner ear. So visual fixation can't completely fix it.
Okay, I'm starting to see the difference. The nystagmus is really giving us clues.
It is. Now let's move on to another key difference. Postural instability.
Okay.
We talked about how vertigo can make it hard to keep your balance.
Right.
But is there a difference in postural instability between central and peripheral vertigo?
Yeah, good question.
There is. With peripheral, the instability is usually unidirectional, so they tend to fall or lean in one specific direction.
Right.
But they can still walk, okay,
Right.
generally.
So they might sway or stumble, but they can walk without help.
Right. Now, with central vertigo, the postural instability is more severe and can be in multiple directions. So
Mhm.
they might have a wide stance, stagger,
Mm-hmm.
maybe even fall when they try to walk.
That sounds a lot more worrisome,
Yeah,
which makes sense if the problem is in the brain itself.
exactly. And remember, we talked about associated symptoms too.
Yeah.
Hearing loss, tinnitus, those usually mean peripheral and
Mhm.
neurological symptoms like double vision,
Yeah.
slurred speech, weakness. Those point towards a central cause.
Okay, I feel like I'm getting better at telling these two types of vertigo apart.
Good.
We're looking at the nystagmus,
Right.
the postural instability,
Yeah.
and any other symptoms.
And those differences help us decide when we need to do more testing. Like if you think it's central, maybe you need an MRI.
Right. Got to be smart about ordering tests, but also not miss anything serious. Now, I noticed some research focuses specifically on positional vertigo.
Yeah.
Can you tell us more about that?
Sure. Positional vertigo, that's dizziness triggered by changes in head position.
Right.
BPPV, the one we talked about earlier,
What?
that's a classic example of peripheral positional vertigo.
And we use the Dix-Hallpike to diagnose that.
Exactly.
But there can be central causes too, right?
There can, yeah. And the way to tell them apart is by looking at the timing and characteristics of the nystagmus.
Okay.
With peripheral positional vertigo, there's usually a delay of a few seconds before the nystagmus starts after you move their head.
Okay.
And then the nystagmus itself, it lasts less than a minute, and it tends to get weaker if you repeat the maneuver.
So if we do the Dix-Hallpike a few times,
Yeah.
the nystagmus should lessen.
Exactly. But with central positional vertigo, there's often no delay. The nystagmus might last longer than a minute,
Right.
and it might not get weaker with repetition.
Wow. It's amazing how much these little details can tell us.
They really can, and they can
Yeah.
make a big difference in how we proceed. Now, I think we should touch on a really tricky scenario. Dizziness when someone's also had syncope. Okay, yeah, that sounds complicated. Dizziness can be a symptom of lots of things that can also cause fainting.
Exactly. It's a real head scratcher sometimes. So when a patient has dizziness and a history of syncope, or near syncope, we got to be thorough and consider all sorts of possibilities.
Yeah,
Luckily, research can help us here.
good.
One study nicely broke down syncope into two main groups.
Yeah.
Cardiovascular and non-cardiovascular causes.
Makes sense. Syncope or fainting is that brief loss of consciousness from reduced blood flow to the brain.
Right.
So it's logical to figure out if the root cause is related to the heart or not.
Right. So the cardiovascular causes include things like arrhythmias,
Mm-hmm.
structural heart
Oh,
disease,
wow.
even pulmonary embolism.
Oh, yeah, those are all serious and
Yeah.
need quick action. But what about the non-cardiovascular causes?
Well, that list is even longer. We've got reflex mechanisms like vasovagal syncope,
Mm-hmm.
orthostatic hypotension, medication side effects,
Right.
and even psych stuff. Wow, that's a lot to keep in mind. It really shows how syncope can come from a ton of different things, not just heart problems.
Exactly. Which is why a thorough history and physical are so crucial.
Yeah,
We need as much info as possible to narrow things down and figure out what tests to order.
right.
The research even breaks down these categories further, highlighting specific conditions to think about. For example, under cardiovascular, we see supraventricular tachycardia,
Mhm.
long QT syndrome,
Oh.
even myocardial infarction.
Those could all really mess with heart rhythm and blood flow,
Yeah.
leading to syncope.
Exactly. And on the non-cardiovascular side, we
Mhm.
see things like, well, defecation syncope and
Yeah.
carotid sinus hypersensitivity.
I've actually had patients pass out while, well, straining on the toilet.
It happens.
It does. It does. And these reflex mechanisms, they can be triggered by different things, leading to that sudden blood pressure drop and fainting.
Wow.
The research also mentions things like hypoglycemia, hypoxia, and even migraines as potential causes of syncope. It's incredible how many different ways someone can lose consciousness.
It really is. And this research highlights something important. In about 50% of patients who go to the hospital with syncope,
Yeah.
we never find the cause.
So even with all the tests and everything, we might not have a definitive answer.
That's right. And that's why talking with our patients and making decisions together is so important.
Yeah.
We got to be honest about what we know and don't know and
Yeah.
work together to come up with a plan that fits their needs and worries.
It really reminds us that, well, sometimes we just don't have all the answers, even after doing everything we can.
Yeah, that's true.
But we can still be there for our patients, reassure them, and support them,
Right.
which is, a huge part of what we do.
Totally agree. That trust and rapport, it's so important,
Yeah.
especially with something like dizziness,
Right.
which can be, well, pretty scary for people.
Absolutely.
Mm-hmm.
Before we wrap up this deep dive, I want to emphasize one more thing.
Mm.
How important it is to think about the patient's age and overall health when we're figuring out what's causing their dizziness.
Oh, yeah, for sure.
We talked about older adults,
Mhm.
but this really applies to everyone, right?
Absolutely. Age, other medical conditions, medications, all that stuff can influence what's causing the dizziness and how
Yeah.
it shows up.
Yeah. A young, healthy person with sudden vertigo.
Right.
That's probably a different story than an older person with lots of health issues and a whole bunch of meds.
Completely different. We're not just treating dizziness, we're treating the whole person, you know?
Exactly. It's all about putting the pieces together and finding the right approach
Yeah.
for each individual patient, which is really what being a GP is all about.
Well said.
I think we've covered a lot today.
We have.
We talked about the types of dizziness,
Mm-hmm.
how to tell them apart,
Yeah.
and even some of those tricky situations where it's hard to get a diagnosis.
Yeah.
Hopefully our listeners are feeling more ready to tackle dizziness in their own practices.
I hope so.
But as we wrap up, I want to leave you with something to think about.
Okay.
With so many possible causes of dizziness,
Yeah.
what strategies can you use as a busy GP
Mm-hmm.
to make your diagnosis process more efficient without missing anything important? How can you be sure you're considering everything?
That's a great question. I think the key is experience. The more you see and the more you learn, the better you'll get at helping your patients with this tricky symptom.
Couldn't agree more. And that's a wrap on our deep dive into dizziness. Thanks for joining us, everyone. Keep those minds sharp and those patients steady.